You are most welcome to this video. Today I'm mostly going to be looking at a study from the United Kingdom, but it's got implications wherever you live because it's telling us some fairly fundamental things about the nature of this pandemic, really. Now, this is the REACT study. Now, the REACT study is in two parts. There's REACT 1 and REACT 2. So REACT 1 is a monthly survey looking at the antigen prevalence in the community. The antigen being the virus, that is the amount of disease, COVID-19 disease prevalence in the community at any one time. So that's REACT 1. REACT 2 is looking for the presence of the antibodies. It's a roughly monthly survey looking for the presence of the antibodies who's had the disease over the past few months. So this data is about the REACT 1 study, which is about the prevalence of the antigen. So this is short for real-time assessment of community transmission. So studies these days always have to have some sort of acronym like this. So I guess that's REACT, but of course people react to the presence of the virus. So I must say it is quite a good name. So this is from Imperial College London. This is where it's based. Commissioned by the Department of Health and Social Care, using Ipsos MORI, the polling people, as their way of developing samples and getting this to be scientifically representative. Now, I do stress this a little bit because it's always important to look at where the data is coming from. So this is Imperial College, National Institute of Health Research, Ipsos MORI, Department of Health, in support of the NHS. So all these people look fairly reputable. Now, just because you put a logo on a website doesn't mean to say it's true, but these are genuine. I have checked these out. So this is reputable data because what we have to make sure that what we're talking about is valid. Now validity is the extent to which something does what it says it does. So if it says beans on the tin and it's beans inside, that's a valid claim. But if it says beans on the tin and it's peas inside, that's not a valid claim. And I just stress this because there's so much disinformation that's been annoying me lately. So we have to make sure about the validity of our sources. And this is actually as good as data gathering gets in the UK. We looked at the Office for National Statistics data yesterday, and this is highly complementary to that. So it's antigen and antibody testing surveys. So REACT 1 is the antigens, the antibodies is REACT 2, wing of the same study, really, but done separately. So this is repeated. So it's done most months. It's non-overlapping. That means different people every month. They are randomly chosen by Ipsos MORI. Now, if polling agencies and these marketing agencies know how to do anything, it's how to pick a random sample. And that means you take away the human subjectivity. So that means you get a good sample, and a random sample is genuinely representative of the total population. That is the whole population of not the UK actually, this is just done over England. It's an English study. It's cross-sectional. That means it's taking information at any one time. The converse of cross-sectional would be longitudinal. So it's just what is happening in this particular period of time. And it's random, meaning it's actually representative of the population. So good research techniques. So reputable agencies, good research techniques. Self-administered throat and nose swabs and questionnaire data. And there's a lot of questionnaire data. So that is well done also. And this is a test, an antigen test, which is done. Antigen being the virus, irrespective of whether people have symptoms or not. So this is going to pick up symptomatic and asymptomatic individuals as well. The only slight downside of this really is people have to agree to take part in the study. And then when you agree to take part, they actually send you the materials. So you could say that the people that agree to take part are going to be more interested in the pandemic, more interested in controlling the pandemic, more likely to comply with the requirements of social distancing and mask wearing and hands, face, space, ventilate and all that sort of stuff. So given that these people are probably people that comply anyway, you could argue with some justification that these are underestimates of the total amounts of people that are infected at any one time. So really, I think these are minimum estimates. The real situation could be could be slightly worse. But let's carry on. So to estimate the community-wide prevalence, remember the incidence is the number of new cases, the prevalence is the number of cases at any one time, unbiased by testing availability or behaviour. So it's nothing to do with whether tests are available in your area. These tests are sent out directly by the researchers for use with the researchers. They're not for diagnosis, they are for research purposes. Now, it's 28th of January today, isn't it? So this is just reported today. React 1, now this is round 8, and this is the final report of round 8. So they've been doing this for over 8 months now. Now, England during January 2021 was the time period under consideration. And this is kind of the bottom line I'm giving you at the start. There's a high average prevalence. So basically a lot of people have been infected with SARS coronavirus 2 in England during January. We knew that already, of course, from the hospitalisations and the other problems that flow from this, but this confirms it. It's always good to have the science that confirms this. Good, randomised, proper data, well analysed data, good quality research stuff. Now, regional heterogeneity. Heterogeneity, good word. It means it's different in different areas. So homogeneity would mean it would be the same everywhere, like homogeneous means the same throughout, whereas heterogeneous means different. So quite different in different parts of England. And then we've seen this all around the world. We've noticed this in the United States quite a bit. Different states having a higher prevalence, other states having a lower prevalence, and that changing over time. It's a dynamic state. As time changes, the prevalence changes in different areas, and it kind of doesn't go, unfortunately, but it does reduce somewhat in certain areas. So basically it's looking for SARS coronavirus 2 infection in the community, of course. So that's the nature of the study. Now, React 1, survey of prevalence in the community in England, repeated cross-sectional samples, as we've said, so all fine. Now, this is data here this round is between the 6th of January and the 22nd of January 2021. So the prevalence, the percentages that are given are the number of people that tested positive in that time period, 6th to the 22nd of January. So this is cross-sectional between these two dates. Now, they actually got results from 167,000 individuals. Now, that is just an amazing sample size. I mean, a normal Ipsos MORI poll to work out who's going to be the next Prime Minister would have about 1,000 people, and they get good results from that. So we've got 167,000 people returning samples. So encouraging to see that people are prepared to take part in this research, and also an excellent sample size. I mean, a lot of researchers would give a lot for sample sizes of that nature. There was 2,228 came back positive, giving a weighted national prevalence of infection of 1.57%. So that was the overall English average prevalence during these dates. Now, how sure are they of that is the next question. Well, they give that information. They give that information because it's good research. They are 95% certain the actual prevalence was between 1.49 and 1.66. So the figure they give is 1.57. And they are 95% confident it's in between those two parameters. So pretty tight, really. This is actually fairly precise. And the reason they can be so precise is because there's such large numbers. The larger the numbers, the better the stats you can get out of those numbers, of course. Now, no strong evidence for either growth or decay average during that time period. So between the 6th and the 22nd of January, and of course we would expect the lockdown to start taking effect by the end of this period. It did to some extent, but there's no strong evidence. So there was a bit of a reduction towards the end of this period, but it's nothing they could give scientific proof to. Now, if there had been a more steep prevalence, as there was in the first lockdown, then that would have reached scientific significance and they could have said there was. So What this is saying is between the 6th and the 22nd of January, the reduction in cases was very gradual. The decline is very gradual considering all the efforts that we are making in the UK, and we'll be seeing the reasons for that shortly. So the R number was basically not far off 1, 0.98, so a very, very gradual reduction. And again, they were 95% sure the actual R value in this time was between 0.92 and 1.04. So again, a pretty accurate estimate of the R value in England as measured by antibody prevalence. So why not more reduction in cases given that we're fairly locked down now? Very disappointing result. Why not more reduction in cases? Well, there's been a higher average level of mobility, unfortunately, in the UK. That's one factor. Now, this is measured by Facebook and Google data, I think, but was it? I can't remember. It was one or the other. Anyway, it's internet data that people were more mobile during this time period than they had been in the past. More people are allowed to physically attend their workplace. I mean, obviously, people should be working from home if they can, but a lot of people are physically attending workplace. Therefore, of course, the risk of cross-infection. And a larger number of children eligible to attend school. Of course, schools are closed now with the lockdown, but there's still quite a lot of children actually go to school because of the exemptions for essential workers and people like that who still send their children to school. So a relatively large number of children eligible to attend school. And the biggie, they don't classify these, but I think the main factor is high intrinsic transmissibility of the new variant. This new variant has been a complete disaster for the United Kingdom. There's no two ways about it. 55% more transmissible. Now, what about the trend during this period of time? Prevalence remained high throughout with suggestion of decline. So suggestion, looked like it went down a bit, but not much. Very disappointing. Different in different areas. Decreasing prevalence in the southwest. Which is good, but increasing prevalence in the east and Midlands. So different parts of the country, different patterns. London remained high, very high prevalence in London. As indeed it said. So prevalence 6th of Jan to 22nd of January. Prevalence highest in London overall for all of London. 2.83% of the population of London had the virus, had the antigen during this time period. Getting on for 3%, isn't it? Very high prevalence in London. There was a lot of infection about. And of course, this has been seen with the terrible situation in London hospitals and the deaths that have followed from that. People from intensive care units in London being transferred to different parts of the country that weren't as badly stretched in terms of intensive care capacity. Prevalence nationally highest in age, right. So this is the prevalence all over England. So nationally, the prevalence was highest in the 18 to 24-year-old age groups, and in the 18 to 24-year-old age groups, 2.44% of the entire number of people that are 18 to 24 were positive during that time. And those over 65 years of age, there was also an increase from early January. So 0.3% of all the people over 65 in the country, 0.3% of all the people aged over 65 in the country had the antigen. They had the virus. At some point during the 6th to the 22nd of January. And of course, this is concerning, because these people are going to carry on getting sick and being hospitalised for weeks into the future. So it's not too encouraging a picture overall, really. Correlations for highest prevalence. Now, you can't say there's causality here, but these were correlations. Actually, the paper doesn't actually talk too much about correlations, but that's actually what they are. As far as I can see, they are correlations. Large household size, as we know, is a factor, especially multi-generational households. Now, single-person households, of all the people in England that lived in single-person households, 1.9 to 4% were positive during that time for the virus. Households of 7 or more people, 3.05%. So a clear trend there, and there was a clear increase as well. So 2 in the household, 3 in the household, 4 in the household, 5 in the household, 6 in the household. It went up progressively. So larger household size, particularly with multi-generational households, clearly a risk factor for positive antigen testing. Living in a deprived neighbourhood. Now, the 2 most deprived quintiles, prevalence was 1.79%. The 2 highest quintiles, 1.22%. So quintiles means 20%. So basically, the two most deprived quintiles were the lowest 40% of the population, and they compared these with the highest 40%. I guess they just ignored the bit in the middle. So the 40% of the population in the lowest socioeconomic areas and the 40% of the population in the highest economic areas, compared those two, and they found that these ones had 1.79% and these ones in the higher socioeconomic areas had 1.22%. So again, a fairly clear difference there. Doesn't tell us why. Doesn't tell us whether it's related to lack of resources, like difficulty in buying nutritious food, or whether there is a behavioural difference between the two areas. Doesn't tell us that. We don't, from this survey, we don't know that. It's just telling us. It's very important not to read too much into this. It's just telling us what it's telling us. We have to stick to what we actually know. Black and Asian ethnicity. Now, we have been talking about this on this video, on this channel since February, because it's quite simple. The darker the coloured skin, the more slowly you produce vitamin D. You know, this is known, but again, not mentioned in the survey. Seems to be a national blind spot for some reason, despite the attempts of David Davis and myself on this channel, and David Davis slightly more influentially in Parliament. But no, serious difference here. Black and Asian ethnicity, increased prevalence, 3.07%, as opposed to the white population, 1.14%. Again, this survey does not tell us why. I'm just saying it would be nice if we could increase the vitamin D levels in this group, because we know they have lower vitamin D levels than this group, and that would account for that factor. Then if the difference were still there, we could go looking for other factors. But anyway, that's me speculating. This is what we know. We don't know why from this survey. We just know that is what it is. Healthcare and home care workers. Healthcare and home care workers, their prevalence was 1.48%. Other workers 1.35%. So not a huge difference, but a definite effect there. So and because the numbers were fairly large, this difference is significant. So a slight increased risk of prevalence for the virus in health and home care workers. More likely to catch it at work. This is called healthcare acquired infection, or nosocomial infection. If you catch an infection in a healthcare setting, that's a nosocomial infection, or a healthcare acquired infection. Now, of course, this can apply to staff who can catch infections, but it can also apply to patients who can also contract infections in hospital. Still nosocomial or healthcare acquired infection. A little bit about so other key workers. So doesn't specify what these are. One would imagine we're talking about fire services, police services, perhaps teachers. Doesn't say what they are, but they had a higher incidence as well. Sorry, higher prevalence as well, but they don't specify that, so we don't know. Now, the context of this, prevalence in infection in early to mid-January, this is during the first part of the study, has been the highest since May 2020. Now, the prevalence could have been higher in February 2020. We don't know, because this study only started in May. But and by May, of course, we were gaining, not suffering, we were gaining from the benefits of the first lockdown. So all we can say with certainty is this is the highest since May. It probably was higher. There probably was a higher prevalence in February, March in England. But we don't know that from this study, which is what we're considering today. We're going to try and stick to the evidence. So highest since May, high rapid increasing prevalence in the second wave. So in other words, the prevalence now is higher than when the prevalence was being measured in the first wave, and it's not going down as quickly. It's not going down nothing like as quickly as the first lockdown had much more dramatic effects than this. So partly a more transmissible strain, as we've said. This strain was first observed in southern England in September 2020. Now, if you don't live in England, take careful note. September. So September, October, November, December. 4 months before this caused massive problems in the UK. Because you might start off with just 4 cases of the new variant. Then 7, 8, 9, 10 days later there could be 8. Another 7 or 8, 9 days after that there could be 16, 32, 64. But then all of a sudden it takes off because this is exponential growth. This is why there's so much problem now in Portugal, why there was such a big problem in Ireland, and I fear the United States and Canada could be in this delay now, making it a real risk between vaccinations and infections in those areas. So this new variant, which has caused such devastation in England, all over the UK, in January, has been brewing slowly since September and did not become very prevalent until about 3/4 of the way through December, really. It was about the 20th of December that people started realising this was really, really quite a big problem. That's why Christmas had to be curtailed at such short notice. So, bit of a warning sign there, really. 4-month delay, but now it's causing these appalling effects, and they are appalling effects. Right, some conclusions here. Infections remain much higher than those seen during the lockdown in May. They're not going down as quickly. It's disappointing. Very shallow downward trajectory. Unless the prevalence of infection in the community can be lowered substantially, the authors say the extreme pressure on the health service will continue over the coming weeks and possibly months. This is going down slowly. The prevalence is increasing in those aged over 65. So there's going to be a demand on hospitalisations for weeks and even a month or 2, or even maybe 2 months into the future. We're not out of the woods yet by any means. Until the vaccination programme protects sufficient numbers of at-risk individuals, vaccination is the way out of this. Don't let anyone tell you otherwise. Essential, we continue to observe public health measures, social distancing, face covering, hand washing, isolation of all cases, and of course ventilation. Direct quote, if substantial lower prevalence is not achieved rapidly in England, pressure on healthcare services and numbers of COVID-19 deaths will remain unacceptably high, and right now they are unacceptably high. So, new data just out today, data of a high calibre, going to carry on being difficult for some weeks into the future in the UK, and a severe warning for other countries where the new prevalence is already spreading. Now I've got a video to show you. Hopefully it'll work. Let us try. Now, Christine was asked to take part in the React 2 study for the antibodies. What we've just been looking at is the REACT-1 study for the antigen, but she was asked to take part in the REACT-2 study for the antibodies to check if she's had infection perhaps in the last 3 or 4 months. So let's see what happened there. And thanks to Christine for this video, and indeed her husband, who took the who recorded the video, just to guarantee to you that no households were mixed during the making of this video. Well, Christine's been chosen to take part in the REACT-2 study. This is the study for the antibodies. The REACT-1 is the study of the antigens, the presence of the virus. The REACT-2 is the presence of the antibodies that are made in response to the presence of the antigen. Antigen being short for antibody generating molecule. So Christine wants to find out if she's got these antibodies in her blood. So there's the finger pricker, and she's going to prick her finger to get a small capillary blood sample. And she's got the instructions in front of her that she's just checking. So there's the instructions that are provided with it. So time to prick your finger, I'm afraid. Now, if I'd been doing this, I would have pricked my finger on the side, so I'm not using the tips of my fingers, which are the most sensitive part. That's the way she's chosen to do it. A bit of a squeeze. What have we got? Yeah, there we go. So that's the capillary blood sample. Now you can suck that up with that sucker on the left there, or you can just put it into the tray directly, into the test tray directly. And Christine's chosen just to put it into the test tray directly. So there's the blood in the test tray. Now, to help it rise up the through the filtering columns to check for the presence of the antibodies, the test comes with some solvent. So 2 drops of the solvent go on there. This is all really clearly spelt out in the instructions. And there we go. Now the test does say wait 10 minutes before you read the results, so we take a note of the time. And we'll come back in 10 minutes to do the second part of the test, which is the reading. But we can see there the fluid is already climbing up through the filter medium to give us the results. We've got to wait for 10 minutes. So it's now 10 minutes later, and Christine has put the cassette onto the recording area where you take a picture of it. But we can see that it is negative for the IgM and the IgG. The control has come up positive, so it means the kit is working. So all you do now, when the correct time has elapsed, there we go, it's now 10 minutes later, she's going to take a picture of it, and then that picture is sent off to the researchers, who will then interpret the results. But this result clearly is negative. And then once you've got the photograph that you think is a good one to send back, you just send it back to the email address provided, and that is it. You've taken part in the REACT-2 study. Excellent. Well, thank you for sending that in, Christine. Very interesting. You know, that looks so simple. This is actually the test that Christine was using here. It looks so simple, but that's actually testing for really quite sophisticated antibodies. So, yeah, there we go. So that was the actual test. Maybe we can go in a bit. Yeah. So the drop of blood goes in the bottom there, and then the IgMs. If there's a line there, that means you're IgM positive, which would mean that you've been recently infected. And if the IgG line goes positive, that means you've been infected slightly longer ago, and that's the control there as well. So that was all interesting. But this is clearly a negative, although it's up for them to decide that. But of course, I'm sure they will. And I thought it was just quite neat and handy, really, the way you send it in by take a picture and send it in, basically. Now, I'm going to deal with a few questions now from Michael about the new variants. So I haven't really rehearsed these. I'm just going to answer them as best as I can. So Michael asks how the UK variant, for want of a better term, is more transmissible and more deadly than the original virus originating in Wuhan. So why is it more transmissible? Well, we know that there's differences to the spike protein. And the spike protein is on the virus, and it's the spike protein that fits into the cells. This is the ACE2 receptor on the cells where the virus gets in, and it forms a stronger chemical bond. So it forms a stronger chemical bond with that receptor site, and that lets the viral RNA into it. And there's also some studies that suggest that people with the new variant have a higher viral load and are shedding more of the virus, so they're producing more droplets and aerosols that contain the virus, as well as that higher binding affinity. So more transmissible, what does more transmissible means? It means that if someone's got it, they are 55% more likely to pass it on to the next person. In other words, to put it simply, it spreads easier. Can the virus travel for longer distances through the air? The answer there is probably not, because the distance that a virus travels through the air is dependent on the water droplets that the virus is in. So the large droplets will drop out fairly quickly. The smaller droplets will be aerosolized, and we know that they can diffuse for some meters, especially in a poorly ventilated environment. That's why it's so important we ventilate our environment. So it's not that they're spreading further. So it's that they're binding with stronger affinity into the ACE2 receptors, and people are probably shedding higher numbers of them. It's not that it travels further through the air. It is not more motile in that respect. Does it last for longer on surfaces? No, as far as we know. We still, the original data going back to February now, the virus basically survives for about 3 days on a hard surface at normal temperatures and pressures, less if it's exposed to sunlight. So this new virus does not last for longer on surfaces as far as we know. Is a lower proportion of the virus sufficient for causing infection, the inoculum dose? Well, given that it has a higher affinity for the receptor site, I think the answer to that is yes. So it would make sense that someone can be infected with a lower dose of virus with the new variant than with the old variant. That would make perfect sense. Are there any implications for distancing rules? I would say yes, they are, because it's more transmissible. So the further we are apart from people, the better, because it's more transmissible. So if the virus was not transmitted at 2 meters, 6 feet before, maybe now it could be. So yes, we want as much distance as we can. Also, what does deadlier mean? Well, deadlier relates to the mortality. Now, we believe that this virus is more dangerous. We saw yesterday information from the Office of National Statistics that shows that people generate more clinical features, all of the clinical features, apart from the loss of smell and the loss of taste, which actually seems to be less with the new variant compared to the old variant. But other than that, it seems to generate more clinical features, and it also seems to kill a very small amount, but to some degree kills more of the people that are infected. About 30% increased mortality perhaps with the new variant from the data that we have. And then Michael's last question, does it kill more younger people, or is it just deadlier among the risk groups? So the increase in risk of death from this virus, which does seem to, the new variant, which does seem to be about 30% compared to the old variant, is the same in all age groups. So it's not that this new variant is attacking younger people specifically. It's attacking everyone. It's transmitting to everyone more readily, and it's causing more clinical features in everyone. And it's also got an increased mortality in everyone. But thankfully, the mortality was so low in younger people that a 20 or 30% increase in mortality in younger people still means the mortality is incredibly low in young people. But the relative risk, not the absolute risk, the relative risk has increased. So I hope that helps, Michael. Just a few questions there. Let's just finish with a couple of pictures if we have the technology. These are from Debbie. Debbie's a teacher, so it's good to see that the information is there on the school wall, so that's good to see. Excellent. Now, looks like there's good distances between the seats here, Debbie, but my question is, and the one you can't see here, is how good is the ventilation? Because if this is in a stuffy environment, the virus could diffuse gradually over time. But given that you are so fastidious in your preparations, I am sure you've also ensured good ventilation, even if that means the classroom is a little chilly. Now, this is good. Debbie uses this if people come within 6 feet of her. This is actually about 6 feet 6, this pole, I believe. But she can shoo them out the way. So she's able to maintain a safe distance. And if the ventilation was also good, then this is going to reduce viral transmission more effectively. So good advice there, Debbie. Everyone could get themselves a pole which is 6 feet or slightly longer, and shoo people away if they get too close. So I think that is an absolutely brilliant idea and an excellent demonstration. Have a little pole, paint it bright red if possible, and shoo people away to a safe distance. There we go. There we see. I assume that Debbie sent these in ages ago. I've been very lax at putting them up, but 6 feet of safety, it's further than you think. Great examples, Debbie. Teachers always think of good practical illustrations like that. So thank you for sending that in. And that's us for today. We're not out of this yet. There's some difficult times to come. And do remember, if you're watching in the United States, that the new prevalence has been in the UK since September, but didn't become a problem till December. And given that the new variant is spreading in the United States and other countries now, like Canada, it is absolutely vital that you maintain all of the restrictions and hands, face, space, ventilate, isolate policy that you have been doing. And of course, we are getting the vaccine just as soon as we can. Oh, one more thing. I've been meaning to buy myself some more shirts for ages, but never got round to it. It's just never had the time, really. And someone sent me some shirts in, so this is one of them. Now, I don't know who you are, but it really is very kind of you. So I'm just really quite bowled away by that. So hopefully I'll be slightly less scruffy on future videos. And yeah, it's just really kind. So thank you, whoever you are. Do let me know, and I will mention your name on the recording. But I've been meaning to get around to it for ages. We've just never had the time. There's always something else to do, unfortunately. But there you go. Thank you for that. And thank you to everyone, of course, for watching.